Welcome to my opthal teacher. My previous lecture was on primary open angle glaucoma. So we'll be talking about primary angle closure glaucoma today. Now I want to emphasize that it is a spectrum. It is not one condition. That is why I've named it as primary angle closure disease. And primary angle closure glaucoma is just one point in the spectrum. Okay. So let us understand. By definition, primary angle closure disease is a spectrum of conditions in which the peripheral iris moves forwards, as you can see here in the diagram. The peripheral iris moves forwards to block the opening of the trabecular meshwork in an occludable angle. Now, this term is important. Occludable angle basically means an anatomically predisposed angle, right? Such that if the peripheral iris moves forward, there is a blockage and there is a obstruction in the outflow of aqueous, thereby causing a rise of intraocular pressure. So there has to be three things. Occlusion of the trabecular meshwork by the peripheral iris, something known as iridotrabecular contact or ITC, in an anatomically predisposed eye, leading to obstruction of aqueous outflow. So all the three criteria have to be there. Epidemiology. So please try to recollect the epidemiology of primary open angle glaucoma. We're talking about primary angle closure today. So this is common among Asians and Eskimos, less common among Africans and Caucasians, occurs in the 5th to 6th decade among Asians. In Europeans, it may occur a decade later. 50% of primary adult glaucomas among Asians. So if you remember the epidemiology over there, we discussed that the ratio of POAG and PACG is a 1:1 among Indians, right? So 50% of primary adult glaucomas among Asians, females more commonly affected by PACG, and first degree relatives are at increased risk. Those are the risk factors. So age, advancing age, females, gender, Far East and Indian Asian populations in whom non-pupillary block mechanism is more significant. In the subsequent slides, we'll be talking about mechanisms and of course a positive family history. Now, some special risk factors to be noted here are refraction. So eyes with pure pupillary block are usually hypermetropic. I'm going to tell you what pure pupillary block and non-pupillary block means. So for now, just understand that hypermetropic eyes have a crowded anterior chamber angle, which is more prone to getting obstructed. Non-pupillary block mechanism is something that can happen in myopic eyes. Next, axial length. So short eyes have a shallower AC due to a relatively anterior lens position. So eyes with nano-ophthalmos, that is axial length less than 20 mm, are more prone to angle closure disease. So hypermetropes and non-ophthalmic eyes or very short eyes. So this is what I was talking about, the pathogenic mechanisms. So the first thing is a relative pupillary block, right? So this was the first understood mechanism. So relative pupillary block, what does it mean? It means what you see here in this picture. Relative pupillary block. See, first of all, there is a high lens vault. Okay, so that this space, this anteroposterior space, is actually decreased. High lens vault is defined as the distance between the anterior pole of the lens, somewhere over here, and a horizontal line through the scleral spur. The scleral spur is here. Okay, that is a line that is somewhere along this portion. So basically an imaginary line. This is the definition of lens vault. Basically a high lens vault in a layman's term would mean a thick lens. For you to understand, a thick lens, and this type of pupillary block is relieved by iridotomy. So what happens in a thick lens is that this part, the anterior part of the lens, is in contact with the iris over here, right? As a result of which the outflow of aqueous through the pupil is obstructed. So this is what is known as pupillary block. This over here, the thick lens is obstructing the outflow of aqueous from the posterior chamber to the anterior chamber. As a result of which, what is happening is that aqueous is building up in this region. So as aqueous is building up, it is pushing the iris forwards, and that forward bending of the iris is now going to cause a blockage in the angle. So Primarily, the mechanism started here in this part. The problem was here. High lens vault, that is a thick lens, causing a relative pupillary block. A relative pupillary block means that it is changing. That is, it might be noted, it might be more conspicuous when the pupil is mid-dilated to dilate. That is why the term relative pupillary block. So this is obstructed, aqueous builds up, angle closure happens by the peripheral iris. So this is one mechanism. So this is really by route. So basically, if we make a hole here, the aqueous then flows into the from the posterior to the anterior chamber, a communication is established and the pressure is relieved. What happens if the problem does not lie here but somewhere else? So this is a UBM picture. So look at this. This is basically the region of the ciliary body, right? And this is the root of the iris. So normally this part is not visible here. This is an anteriorly placed ciliary body, right? So an anteriorly placed ciliary body, as a result of which there is an anteriorly placed iris which is blocking the angle physically. This is non-pupillary block. There is no problem in the pupillary area. The problem lies here at the angle in an anteriorly placed ciliary body. So this is an anatomical factor. Anteriorly rotated ciliary processes thick peripheral iris, not relieved by iridotomy. Obviously, if you're going to make a hole here, this physical blockage of the angle is not going to go away. This is a common mechanism in Asians. So this non-pupillary block, it was discovered later, and this was also one of the mechanisms of angle closure disease. Of course, there are combined mechanisms in which both the elements are there. That is relative pupillary block and non-pupillary. That is known as a combined mechanism. And then lastly, there is a plateau iris configuration. This is again an anatomical configuration of the iris which predisposes to angle closure disease. We'll be talking about plateau iris in a subsequent slide. So that is about the pathogenic mechanisms. So now we know about two mechanisms: relative pupillary block, which consists of a high lens vault, and non-pupillary block, which consists of anteriorly rotated ciliary processes. These are said to be the underlying mechanisms of angle closure disease. So how does angle closure happen? This, you see the diagram here. This, the black, the black box over here is indicating relative pupillary block. But aqueous is being secreted constantly. So this aqueous is building up in the posterior chamber, and this aqueous buildup is causing a forward bulging of the iris, and this forward bulging iris is going to block the angle in the, that is the forward bulging of the iris. The peripheral iris comes in contact with the angle and prevents aqueous outflow. So a relative pupillary block is combined with physical obstruction of the angle also. This is what I've tried to explain in the flow chart. So if it is a developmentally small eye with a normal sized lens, proportionate larger, this means that, see, as the development is happening, even if the axial length of the eyeball may be small. That's what it means by developmentally small eye. But the lens is normal in size. The lens and the eyeball develop independently, and the lens is normal in size, and it even continues to grow throughout life. So the lens vault is going to go increasing, as a result of which there is a crowding of the anterior chamber, increased area of contact between the iris and the lens. See, the iris is bulging forward, right over here. Increased area between the iris and the lens. That is a result of the crowding of the anterior chamber, causing increased area of contact between iris and lens here, leading to relative pupillary block, in turn causing a bulging of the iris, impeded forward movement of the aqueous through the pupil, leading to an iris bombe. That is the same thing, bulging of the forward bulging of the iris, the peripheral iris especially, when mid-dilated pupil comes in contact with a thick, accommodated and anteriorly placed lens. There is bowing forward of the peripheral iris, closure of large areas of trabecular meshwork. You see, this is sticking to the cornea, right? The peripheral iris is sticking to the cornea over here. The angle is absolutely obstructed. So closure of large areas of trabecular meshwork, leading to a rise in intraocular pressure. So this is the etiopathogenesis pathogenesis of angle closure, showing the relative pupillary block mechanism. This is not explaining the non-pupillary block. This is the explanation for the relative pupillary block mechanism. The second mechanism is the non-pupillary block mechanism, which I have explained in the previous slide. So earlier we as students used to read the classification of when we used to read the classification of acute angle closure glaucoma, we used to read acute, chronic, subacute. This was the classification, right? But with more and as more and more things have advanced, and we are now more familiar with the angle structures and all of that. There is a new classification system. So this has been given by this particular body, Association of International Glaucoma Societies. So when somebody asks you, how do you classify angle closure glaucoma? We classify the angle closure. First of all, it is not angle closure glaucoma. It's an angle closure disease. It is a spectrum, and this spectrum consists of three entities: primary angle closure suspect, primary angle closure, primary angle closure glaucoma. Please remember, this is a very important slide, and these three definitions are very, very important. So PACS, who is a primary angle closure suspect? Somebody who has iridotrabecular contact in 3 or more quadrants, but normal IOP, disc and field without any evidence of peripheral anterior synechiae. That is a primary angle closure suspect, right? Primary angle closure is when there is ITC in 3 or more quadrants with raised IOP and or primary peripheral anterior synechiae, but the disc and field are normal, so you cannot call it glaucomatous. And primary angle closure glaucoma, PACG, is when either of these two with evidence of glaucomatous damage to optic disc and visual field, just as in POAG. So this is the definition of primary angle closure glaucoma. But primary angle closure glaucoma is not equal to primary angle closure disease. Primary angle closure disease also has these two other entities. So this was the older classification. There used to be a prodromal stage, then stage of constant. If some of you might read some older books, you might find this classification also. Acute congestive, chronic congestive, and then there is a stage of absolute glaucoma. So this is I've just put the slide here for theoretical interest, but then this is not really followed. So coming on to clinical features, symptoms would be, so you might have in patients of angle closure, you might have some precipitating factor. For example, whenever the pupil is mid-dilated, it is prone to precipitate an attack of angle closure. For example, watching TV in the dark, pharmacological mydriasis, suppose you're dilating a patient to look at the fundus, acute emotional stress, systemic meds include inhalers which act as sympathomimetics and they dilate the pupil, cold flu remedies similarly, and topiramate is notorious for ciliary body effusion. So it swells the ciliary body, causes it to move forward, thereby obstructing the anterior chamber angle. So any of these precipitating factors, then intermittent blurring, smoke filled room and halos, rainbow around lights. So this intermittent blurring and halos would happen if there is an acute rise in IOP causing corneal edema. So that is why this intermittent blurring and halos should be asked about. Or if the patient has come with an acutely elevated IOP, he or she might present with an acute red eye, and you would then call it acute primary angle closure glaucoma, or rather acute primary angle closure. That's it. So that acute primary angle closure is characterized by markedly decreased vision. The pressures reach up to levels of 50-60 mmHg, and the vision comes down to even hand movement or perception of light. Redness, periocular pain, headache, and even systemic symptoms like vomiting. So these are just some general signs. So it's a generally bilateral disease with asymmetric involvement. Axial anterior chamber depth less than normal, or anterior chamber is shallow. So you see, you compare it with the normal eye, you see that the anterior chamber is shallow. How do you see this particular sign that you see here? This is the eclipse sign. This is because the iris is bowing forward, and when you throw light from the temporal side, it casts a shadow on the nasal side, right? The shadow is of the iris itself. So this is known as eclipse sign. Okay. Normally, the light should just pass through and the opposite limbus should illuminate. Diffuse pigment smudging because of repeated attacks of iris iridocorneal contact, there can be pigments on the cornea, the posterior surface of the cornea. They are not visible in the picture. There can be pigments on the lens also. Okay, a diffuse pigment smudging, and there can be pigments in the angle as appear on gonioscopy. Then glaucom flecken. Glaucom flecken is basically, this is glaucom flecken. Okay, so glaucom flecken is actually when there is a sudden, it is a sign of subacute angle closure disease. Okay, so there have been these intermittent episodes where where the pressures have gone very high, and the the nutrition of the lens has been compromised, leading to the appearance of ischemic opacification, and these are usually subcapsular in location, and they are known as glaucom flecken. That is the word. Okay, anterior lens capsule opacities in acute angle closure disease. Raised IOP may or may not be there. Gonioscopy would definitely show a closed angle, and optic nerve damage may or may not be there. If optic nerve is damaged, we've already seen what a glaucomatous optic atrophy or a glaucomatous optic neuropathy looks like. So gonioscopy. So gonioscopy is the gold standard investigation for diagnosing this primary angle closure disease. Technically, it is not an investigation. It is basically a part of your examination, right? So gonioscopy is basically visualization. In simple words, gonioscopy is visualization of the anterior chamber angle. So the angle of the anterior chamber is graded according to the number of structures visible. So there are grading systems. So some of the systems like Spaeth also provide information on the width of the iris. The most commonly used system is Schaffer's, and I have shown you the Schaffer's grading over here. So basically, what are the structures that you see in a wide open angle or a normal angle? That the wide open angle is the angle in which you can see structures up to the ciliary body, right? So this dark band over here closest to the iris, that is the ciliary body. Okay, it appears like a grayish band. Please go back and read gonioscopy separately. So right now I'm only talking about gonioscopy pertaining to angle closure disease. And gonioscopy is going to be very, very important to us in the entire series of lectures on glaucoma. So gonioscopic findings, very important. So this one is a wide open angle or a normal angle, right? So that's ciliary body. Widest angle seen in myopia and pseudophakia. Then comes grade 3. So you can no longer see that dark band here, no? So ciliary body is not seen. The next region is a white zone, a white line, and that is known as scleral spur. So you can see the scleral spur, and immediately below that comes the iris. So where is the ciliary band? It is not visible. The angle is a little bit closed, but it still qualifies as an open angle. So a grade 3 or 4 or even 2 may be seen in normal individuals also who do not necessarily have elevations of IOP. So coming on to grade 2, now the scleral spur is also not visible, only the trabecular meshwork is visible. So this is the second dark band is the trabecular meshwork, right? So this qualifies as a narrow angle. And then comes grade 1, that is up to Schwalbe line, only this Schwalbe line is visible, okay? And it is very difficult to identify the Schwalbe line if it is not pigmented. So in this case, they've shown a pigmented Schwalbe line, so you make use of the corneal wedge to identify it. Then comes the slit angle where no structures are seen, but there is still no iridocorneal contact, and angle 0 where there is presence of anatomical iridocorneal contact and no structures are seen. So usually the angle is narrowest superiorly and widest inferiorly. It is also possible in an eye that when you look at the superior angle, you find a grade 1 or a grade 2, whereas in the inferior angles, you see a wide open angle, grade 4 or even grade 3. So that is about gonioscopy, a very important tool to diagnose the spectrum of PACD. Now, easier than gonioscopy is a quick screening method which is known as the Van Herrick grading. So what is done in Van Herrick is that a slit is formed at the temporal limbus. Okay. So I've just shown a diagrammatic representation. So when you form a slit, you see these two bands and a dark space in between. What are those two bands? The anterior band is the corneal, is the peripheral cornea. Okay, the orange one. corresponding to this over here, and the maroon band is the iris, okay, corresponding to this bright band over here, and the space in between shown by yellow and corresponding to this dark space is the anterior chamber. Since you have focused the slit on the peripheral part of the cornea, so this becomes your PACD, or peripheral anterior chamber depth. This yellow portion is the peripheral anterior chamber depth, this thing over here. This is compared with the corneal thickness, that is this line. So basically this dark space is expressed as a proportion of this white line, that is the corneal thickness. So if that value is 1 or more, it is grade 4 wide open angle. If that value is 1/4 to half, grade 3 incapable of closure, that is also an open angle. 1/4, grade 2, should undergo gonioscopy. I told you this is a screening method. So basically if the PACD is 1/4 of the corneal thickness, that is very thin, it is not even half, then these type of angles are prone to angle closure and should undergo gonioscopy, and less than 1/4 is grade 1, very narrow angle on gonioscopy will be visible. It is a clear-cut case of angle closure. So Van Eyck system is basically a screening system useful at the slit lamp with the help of a thin slit directed at the temporal cornea to compare the PACD with the corneal thickness. Now coming on to signs. So when we talk of signs, let us talk about each of the entities and their corresponding signs. So acute primary angle closure, which was earlier called acute glaucoma or acute congestive glaucoma, is basically characterized by markedly reduced visual acuity, even hand movements or PL, markedly raised IOP, conjunctival hyperemia, one of the DDs of acute painful red eye, hyperemia, corneal bullae, shallow AC, aqueous flare, even cells might be there. Non-reactive mid-dilated vertically oval pupil, as you see here. So this is the kind of pupil, and you see the cornea appears hazy, right? See, a magnified view, the cornea appears hazy and you can see these microbullae. The fellow eye may have an occludable angle, that is an anatomical angle prone to closure. So signs of acute glaucoma, then resolved acute angle, primary angle closure. So when the previous sort of attack has, resolved by itself or with the help of medications, there may be some telltale signs. The cornea may continue to be hazy. You might get DM folds because the nutrition of the cornea is compromised. Iris atrophy may be there. You see, patchy iris atrophy. Glaucom flecken, I already told you. There may be irregular pupil because the sphincter has undergone ischemic damage because of that pressure, and optic nerve head findings may be there. Then there can be subacute angle closure. Subacute angle closure means that there are intermittent episodes of spontaneously resolving angle closure, acute angle closure have happened in the past, and these patients will have peripheral anterior synechiae. Subacute as well as chronic will have peripheral anterior synechiae. That is because of repeated iridotrabecular contact, in some places the iris keeps sticking, it becomes tent like, or you can say sawtooth. So this is what is known as primary peripheral anterior synechiae. They happen as a result of repeated episodes of acute angle closure. And then the last is chronic angle closure. The visual acuity may be normal unless damage is advanced, that is the glaucomatous damage is advanced. AC may be shallower in relative pupillary block than in non-pupillary block. IOP elevation may or may not be there. Because of the intermittent ITC, you will see these sawtooth peripheral anterior synechiae and you will see optic nerve head changes. So these are the common signs of subacute as well as chronic angle closure. Some investigations. So gonioscopy, of course. Anterior segment OCT can be used as adjuvant and it can be used for patient teaching and it can be used in research purposes. So what do you see here? You see that there is one isolated PAS or peripheral anterior synechia that is extending from the iris up till the pigmented trabecular meshwork. So this is a sign that suggests that previously angle closure happened and some iridotrabecular contact was there. In the other places, you find that the angle is actually open, but here there is one isolated, peripheral anterior synechia. Okay. Then this is a picture of anterior segment OCT. So basically, anterior segment OCT uses light. Light cannot penetrate pigment. So you cannot see the ciliary body and the pigmented structures behind. You can see the angle. Okay, you can quantify and measure the angle over here. So this is the iris, this is the cornea, and this is the angle, right? So anterior segment OCT, it can actually measure the angle and the width very accurately with the help of calipers. Then we have ultrasound biomicroscopy. So ultrasound biomicroscopy looks like this. So what is the difference? Ultrasound biomicroscopy, of course, uses sound, right? So this can actually see the ciliary body also. So sometimes when you want to see an anteriorly placed ciliary body, if you want to see tumors of the ciliary body, you might use this ultrasound biomicroscopy. Biometry. So lens extraction is now understood to be a treatment modality for angle closure. So you have to do calculation of the lens power, right? So you have to do a biometry if you are planning a lens extraction. So that counts as one investigation. And of course, provocative testing. Provocative testing is not done nowadays. So there are certain tests like this provocative water drinking test. So know that before and after of the test, if the rise in IOP is 8 mmHg or higher, then the eye is like may go into angle closure. Okay, so that test is known as dark room provocative test, and you can read up about it. So just a little bit about plateau iris configuration. So plateau iris configuration is characterized by a flat, slightly convex central iris plane in association with a normal or slightly shallow central anterior chamber depth. Angle recess is typically very narrow with a sharp iris angle over an anteriorly positioned ciliary body. So this is your anteriorly positioned ciliary body pushing the peripheral iris forward, and even the central iris is a little convex, right? So even the central AC depth is decreased, so is the peripheral AC depth, right? A characteristic double hump sign on indentation gonioscopy. So this is where the humps come from. So the in the periphery, the hump is because of the anteriorly positioned ciliary process, this one. And the second hump near the pupil is because of the central part of the lens and because of the way the iris is placed immediately above the lens, that causes the central hump. So two humps, 1 2, this is the central hump, double hump sign of indentation gonioscopy seen in plateau iris configuration. Now, plateau iris syndrome would be when there is a persistent angle closure despite a patent iridotomy in a patient with morphological plateau iris. So suppose you see this patient and you find that the pressures are increased. What you do is you do a peripheral iridotomy. We're going to discuss that. Despite the peripheral iridotomy, if the pressures continue to be raised and the angle closure is persistent, then that is known as plateau iris syndrome. So this is another, this is another anatomical predisposition for angle closure. So I told you the three mechanisms: pupillary block, in which the lens vault is high; non-pupillary block, in which the ciliary processes are anteriorly placed; then there is a combined mechanism; and then there is a plateau iris configuration, which is this one. Differential diagnosis of acute IOP elevation, you have to know all of these. Many a times it can be lens induced or phacomorphic glaucoma as it is called, malignant glaucoma, other causes of secondary angle closure with or without pupillary block. I'll try to discuss those other causes in subsequent lectures. Neovascular glaucoma, pigment dispersion, pseudo exfoliation, and of course orbital retroorbital lesions. So let us talk about treatment. So as ophthalmologists, we have come across this acute angle closure attack. It's a very, very common thing, and we have come across so many patients, and it is imperative for us and even for you, as be it undergraduates or postgraduates, to know this very basic initial treatment of an acute primary angle closure attack, as it is commonly called, or acute congestive glaucoma, right? This is the very basic. It is a emergency in ophthalmology. Okay, so what initial treatment will you do? Supine position, it helps to shift the lens posteriorly because of gravity. Acetazolamide 500 mg IV or orally. If the pressures are very high, IV would work faster. Orally would also be useful. You have to rule out sulfa allergies first. Okay, any sulfa allergy, this acetazolamide is contraindicated. You would then have to use alternatives such as glycerol or mannitol. Secondly, what about topical? A drop of prednisolone or dexamethasone is given into the affected eye. Mind you, one drop if there is inflammation. Okay, so at least the inflammation that is contributing to rise in IOP should be controlled. A drop of pilocarpine into the affected eye. So what pilocarpine does is it causes meiosis, and it sort of it pulls the peripheral iris away from the angle, thereby helping in opening the angle. It should be repeated after half an hour, and one drop of 1% pilocarpine should also be instilled into the fellow eye, because many a times the fellow eye is a case of not acute, it's a case of primary angle closure or primary angle closure suspect. So it's a good idea to repeat pilocarpine in the fellow eye also, at least one drop, because there is a very high probability that this eye might also go into an attack of angle closure. And of course, analgesia and antiemetic for the systemic symptoms. If that doesn't work, what do? You can do a manipulative gonioscopy with an indentation gonio lens. It applies pressure to the central cornea, thereby forcing the aqueous into the angle and out of the eye. Topical 50% glycerol can be given for epithelial edema. Okay, you will find corneal bulle in an acute attack. 20% mannitol 1 gram per kg IV over 1 hour, or oral glycerol 50% 1 gram per kg. But before this, you have to rule out congestive heart failure and diabetes. And once the cornea has cleared and the pressure has come down a bit, one can plan for an early laser iridotomy. And once the pressures have settled down, subsequent medical treatment is started. So that consists of pilocarpine 2% 4 times a day and 1% in the fellow eye. Topical steroids 4 times a day to control the inflammation if present. And these steroids are continued for at least a week. Oral acetazolamide 250 mg QID, that is 1 gram, that is the dose, or 500 mg BD can be given. Bilateral laser iridotomy is performed once an attack has been broken, signified by clear cornea and preferably normal IOP. Gonioscopy may need to be repeated to ensure that the angle is open. Had it been a case of plateau iris, iridotomy may not work and angles would still be closed. Now, what do you do with case of primary angle closure glaucoma? That is where the glaucomatous damage to the optic nerve has already happened or the visual fields are affected. Then you continue the medical treatment as discussed. You have to do something definitive. So what is that? Laser PI, trabeculectomy with mitomycin C. These are some definitive treatments. Lens extraction. So even by lens extraction, I mean clear lens extraction. So recent studies like Eagle have shown that the element of the lens vault, which is causing the relative pupillary block, if that element is removed, then the pressures can come down to some extent. So lens extraction is now an accepted line of treatment for acute angle closure. Then phacoemulsification, of course, if there is a cataract. So you see, it corrects the hypermetropia, deepens the AC, opens the angle. And other options include goniosyneciolysis and cyclodiode laser ablation of ciliary body in very advanced cases. What happens if the patient is a suspect? That is, if you only find that there is iridotrabecular contact in 3 or more quadrants. That's it. No raised IOP, no pass, no damage to the optic disc, no visual field changes. What do you do in such patients? So, as a clinician, what I would suggest is that if this patient is going to come to you for follow-up regularly, you can observe, but observation should be strict observation with monthly follow-ups. If you cannot do that, if the patient is a poorly compliant one, it is a good idea to do a laser iridotomy in this eye as a prophylaxis in those with high risk of developing PACG. Especially do it if It is if there is a positive family history, if the fellow eye is non-seeing eye, lost to glaucoma, definitely PI should be done. And the third, it's an unspoken, I'm not written it on the slide. So basically, if the patient is a poorly compliant patient, do the peripheral iridotomy in the fellow eye in which he is a primary angle closure suspect. Cataract extraction should be done if there is one. So it helps to open the angle, deepen the AC. If IOP is elevated, then by definition PAC is present and you treat it along the lines of PAC. Laser peripheral iridotomy is the definitive treatment of acute primary angle closure. So what does it do? It basically makes a hole here. Laser energy is used to make a hole here in the peripheral iris. So an alternative pathway appears for aqueous to enter the anterior chamber. And this channel, this blocked channel is bypassed. So that is a laser peripheral iridotomy. So this is a special lens, that is the Abraham lens. It has a central button which provides a magnification of plus 66 diopters. So this is the Abraham lens, a special lens used to do the iridotomy. It is, applied, it is coupled with a viscoelastic device and it is applied onto the cornea. And then the button is focused in the region where you want to apply the laser energy. And see, this is what a PI looks like. There is a tiny hole in the peripheral iris. So preferably directed at the iris crypts. I'm not going to talk in detail about the procedure. So the laser used is Nd:YAG or argon. The spot size 50, power 3 to 8 millijoules if you are using an Nd:YAG. And the procedure should be completed in 1 to 5 spots. Indications are important. Please learn these indications. Pupillary block with angle closure, pupillary block with narrow angles, such as a PACS, that is an indication also. Chronic angle closure glaucoma, combined mechanism, suspected malignant glaucoma, pseudophakic pupillary block. These are examples where a laser PI is indicated. Some complications include corneal burns, iris bleed and hyphema, cataract if you inadvertently touch the lens, the laser, pigment dispersion. So you have to be careful in patients with PDS, posterior synechiae because of inflammation, uveitis again because of inflammation, transient IOP rise again because of inflammation, diplopia if you've made a very big PI in the interpapillary region, you can cause diplopia, and of course there can be closure of the PI. So that is some complications. Thank you very much. Please stay tuned for secondary glaucomas.